Would you be able to switch the screen? Going to spend some time together to talk about what is mental illness, some of the information, some of the major diagnoses, and a common mental illness that we will see in church setting. And we are going to go through some of the myths and facts and stigma around mental illness. Of course, we have to cover a little bit about suicide, what is suicide and what is the rate, and how, as a church, that we can help prevent it, and what can we do if we notice someone may be struggling with some suicidal urges. And we're going to talk about recovery. How can church be part of a recovery journey, and what does it look like? And then at the end, there will be some time for question and answer. We are going to respond to your questions at the end of the presentation. So if you have any questions, feel free to type it and send it in. And we are going to respond to as much as we could. So I'm going to start with an introduction to mental illness. What is mental illness? So if you look at the so-called the Bible, DSM-5, which is physician using these guidelines to diagnose a person, there are two major characteristics that we would be able to determine. So one is looking at the person's function. So usually the person cannot quite function as before because there is a change in the way they think. There is a change in the mood and behavior. So usually that would associate with a lot of distress. And the distress could be extremely uncomfortable for a lot of people. It could look like a severe anxiety, and sometimes people would feel very depressed. And we would notice there is a lack of focus, a lack of control. People don't want to become like that. They actually try to do something to change their mood, change the way they think, try to will themselves out of it. But they cannot quite do that. So that is causing more distress. And the impaired function would manifest in a way, oftentimes we will see the person may have a hard time staying in their job or perform in their work, or if they are a student, they may have to drop out of school. They may have a hard time catching up with all the schoolwork and focus on examination. Even as a housewife, if someone is not working for any paid employment, even at home, you would notice the person cannot quite function like before. If it is a nursing mom, maybe this mother would have trouble taking care of the newborn baby. So looking at the function of the person is one of the major things when we define mental illness. The other component is how long has these symptoms or these troubles, this distress has been going on. Usually there is a lingering period, and it often flare up as some discomfort, some anxiety, some deprivation of sleeping, and then we will start to notice it becomes more severe, that the person have a hard time to focus on what they want to do. So for different illnesses, the way doctors diagnose it, it varies. Some of those would be a couple weeks, some of those would up to 6 months. And when we get to some of the major illnesses, then we are going to talk more about that. When someone is struggling with mental illness, usually we will see it could lead to unemployment, and we can imagine if I have trouble sleeping, if I have a hard time focusing, if I cannot quite finish and put my will on the things I want to complete, then chances are at some point I will start to fail to perform what I'm supposed to, or maybe because I cannot quite sleep, I cannot quite manage to calm my own anxiety, then I don't want to go to work. I'm afraid of certain tasks. I'm trying to avoid certain challenging conversation or people. Then at the end, I may lose my job. So unemployment is a pretty common effect of mental illness. And when we look at severe mental illness in Canada, it caused at least 30% of the short-term or long-term disability claims, and it leads to 70 to 90% of people becoming unemployed just because of an illness. So in Canada, the other thing that we notice is there are a lot of people who are living on the street. Years ago, we tend to separate those two problems, but when we look at who are these people living on the street, 90% of them, they are actually suffering from severe mental illness. At some point, they start to lose touch with the reality, or they become disconnected with their family and end up on the street. So how prevalent is mental illness in Canada and across all nations in the world? Roughly speaking, we would say it is about 1 out of 4 or 1 out of 5 people who would experience a mental illness in their lifetime. So the mental illness doesn't discriminate according to your income level, your education, your culture, your gender. It's pretty equal in that sense. Anyone can get it, which means in a church setting, simply because you are a good Christian, you are not immune to mental illness. And when we look at some of the research done in the States, they look at pastors, ministers in church, evangelical churches, and ask them, do you think you are struggling with some sort of mental health issues? And 25% of them identify, yes, they are struggling with some kind of mental health issues. So, which is quite alarming at some level, that we used to think these spiritual leaders, these giants that we look up to, if they are close to God and if they are very spiritual, they would not be weak and they would be immune to mental illness, which is not true. And it is also confirming what most research are showing is equal. Anyone can get it. None of us is immune to mental illness. And mental illness could be one of the leading cause of death in Canada. So we know suicide is a very challenging topic these days, and there is a lot of conversation about it. But when we look at some ages, especially the adolescent, the middle age, or some of the senior, it seems suicide combining with some mental health issues, it could be very difficult for these populations. So what are the causes of mental illness? Right now, even though we came a long way, there are lots of research, lots of studies, and there are different theories behind mental illness. We still cannot quite pinpoint one particular reason that we say, this is the reason and that's why you have mental illness. Most people, or among psychiatry, among social work or psychology, still believe it is different components, different things that is contributing to this complicated problem. There is the biological component to it. Sometimes if genetically it is running in the family, people tend to have a higher tendency result in a mental illness. And when we look at some of the MRI, some of these studies, it seems like there is a chemical imbalance in the brains of people suffering from mental illness. So there is that genetic component. But there is also that psychological and the social factors. If someone who are always shy, they have a difficult childhood, they never learn some of these skills to relieve the challenging, distressing emotions, or if they have suffered from some traumatic life events, they have prolonged stress, those could also trigger or contribute to severe mental illness. I'm going to hand it over to Adrian to talk about some of the facts and myths about mental illness.
So in these next couple of slides, I'm going to cover some of the myths that are common, not just in the secular world when it comes to an understanding of mental illnesses, but also in the church. In fact, in the church, perhaps we have another layer that applies to us. So let's look at the first one. Mental illnesses are not real illnesses. And there is this understanding that because you can't see a mental illness on an X-ray or with a blood test, although there is a significant amount of research being done to identify mental illnesses and the biological foundations or underpinnings of it. At this point, mental illnesses are diagnosed on the basis of interviews. And so there tends to be perhaps this feeling that people who claim that they have a mental illness or say that they are experiencing certain symptoms are making it up. This, of course, is not true. Mental illnesses are very real, and people do suffer a significant amount in their lives when they have a mental illness, a mental health diagnosis. So the second one, bad parenting causes mental illness. Well, no one is to blame for mental illness. So, as Purple has mentioned, there are multiple reasons why an individual might be vulnerable to a mental illness. Some of the reasons may be prenatal exposure to drugs or alcohol, abuse, neglect, stressful events, and these things might increase the likelihood why someone might develop a mental health issue. Or why they might struggle with anxiety or depression. But even individuals with good parenting can develop mental illnesses. So thinking that blaming parenting is not helpful. People with mental illnesses are dangerous. Well, there is a myth around that people with mental health problems may be violent or may be unpredictable, but this in fact is not true. In fact, most crimes have been committed by individuals who do not have mental illnesses. And there's a US mentalhealth.gov website which states that only 3 to 5% of violent acts can be attributed to individuals living with serious mental illness. In fact, people with severe mental illnesses are over 10 times more likely to be victims of violent crime than the general population. So let me just flip this slide. Okay, so here's another one. People don't recover from mental illnesses. Well, ideally, the treatment of mental illness involves interdisciplinary and a multi-pronged approach. So it can involve medications and psychotherapy, talk therapy, and in fact, the best results, individuals experience the best results when they use a combination of treatments. And the truth is that treatment works. Individuals who don't get treated tend to suffer more. They suffer more. And looking at our last one here, mental illness shows weakness. Of course, we might have heard that it's a spiritual problem, it's a bad character, a moral failing, there's sin in a person's life, or perhaps they're being lazy. But mental illness is not a faith issue. Even good people can be mentally ill. As Purple mentioned, pastors have admitted, 25% of pastors have admitted that they struggle with mental illnesses. And what's important to know is while prayer helps with gaining support and hope, one can't pray one's way out of a mental illness when they need treatment. So I'm going to stop at this point and hand. I haven't really talked about stigma yet, but can I take a couple of minutes just to do that? Okay, so stigma, what's really important to know is that stigma keeps individuals from getting the treatment that they need. So we can have, emerging out of all of those myths that we've just talked about, prejudice or certain attitudes because of underlying assumptions, which can then lead to behaviors that exclude individuals with mental illness and prevent them from getting adequate health care or housing, jobs. It can really impact their quality of life. The other really important thing about stigma is it isn't only external. At times when individuals with mental illness internalize how the community feels about mental illness, that this is called self-stigma, and this can keep people from admitting that they need treatment and that they need help, and can keep them from seeking help. So this ultimately affects their quality of life. I'm going to hand over to Purple now for the.
So we are going to quickly just go through some of the mental illnesses. How does it look like? What would you notice in a church setting? What are some of the behavior that you may see? Just one word about the diagnosis. So I mentioned about that DSM, which doctors use it to diagnose a person. So if you want to know the specifics, you can go to the American Psychiatric Association and just browse it, Google it, and then type in the specific mental illness that you want to know more. And then usually they have a fact sheet and they have some PDF file for you to download and get the specifics. So some of the common one, there are hundreds and thousands of diagnoses. So we're just going to give you some of those that is more prevalent, and we will often see it in a church setting. So anxiety disorder, it is an umbrella of different kind of illnesses. So usually I would say it really depends on what the person is afraid of, worry about, then the person may get a particular diagnosis. So don't get too hung up on those labels, because oftentimes we see people, they have comorbid illnesses. They could be struggling or suffering from more than one condition. So don't get too hung up on those diagnoses. But some of the common one, so if I'm afraid of certain things, if I'm afraid of the clown, afraid of the height, I'm afraid of closed space, I'm afraid of snakes, those are some of the common one, and we classify those under phobias. The OCD is a short form of obsessive compulsive disorder. The obsessive part is about the thought, and the compulsive part is the behavior. I have to do certain ritual. When I perform it, then I get a temporary relief from the anxiety that has been bothering me, and I will stop to think about, worry about these things for a very short period of time. So one example would be if people, they wash their hands very often, and usually the obsessive part is they are afraid they will contaminate some kind of illness. If they do not do that, if they do not do it in a certain way, do not pump a certain amount of soap, and the compulsive part is once I wash my hands a certain time, a certain period, and go through a particular ritual, then I feel a little better for a very short period of time. So that is one form of OCD. And the PTSD, it seems like a depression, but it's actually classified under anxiety. So usually people have a traumatic experience, and after that, when they have some flashback or certain things remind them of that experience, they are now almost reliving that experience, and the anxiety is so high, then we will see certain behavior, avoiding, trying not to do certain things to avoid that worry, that anxiety. So all these different kinds of mental illnesses, when we look at how it changed the person's thought, mood and behavior. For anxiety, oftentimes is the mood is very anxious. For us, we may think, well, that is illogical. It doesn't make sense. Just get over it. But for the person, because it feels so real, and when people tell them, you don't have to worry about it. There is no point to worry about those things. Just get over it. Focus on the things you want to do, and it will be okay. Or sometimes we hear clients complain, my psychiatrist told me it's all in my head. Those things do not exist. We think by saying something like that would bring some comfort when we tell them the truth, when we confront them with the reality. But chances are when we do that, oftentimes the person will feel, okay, if it is not real, then it must be me. I must be the problem. There is something really wrong about me. But it doesn't ease any anxiety at all. So that is about anxiety disorder. Mood disorder, some of the major ones that we will see would be depression and bipolar disorder or a seasonal affective disorder. Over the winter, people feel very depressed. So usually in the mood, we could see a very depressed mood, but we could also see some kind of depressed mood associated with some manic mood as well. The behavior because of that, we will see people when they are happy. When they are not as depressed, they will show up at church. So oftentimes when we finally we're told, oh, so and so committed suicide because of depression, or so and so end up in the hospital, or now is taking antidepressant, we may feel shocked because our understanding, our memory about the person is, no, last time when we were at the prayer meeting, that person is quite happy, or at the Christmas dinner, the person is sharing the story or receiving our guests. I just cannot see any depressed mood in that person. And that is a very common misunderstanding. And we can imagine if my mood is very low. And my thought is, well, if I go out like this, people will start to worry about me. Or if I go to the church and cannot quite focus, I cannot quite participate, maybe I should not go. So the behavior is when I'm okay, when I sleep well, when I can still mingle with people, have short conversation, you will see me show up at church. But on the days I'm really struggling, you won't see me. So we are just seeing the person when the person is well. That is something about mood disorder. Psychotic illnesses, oftentimes it has to do with a lot of thought problem. So one of the one that a lot of people are afraid of is schizophrenia. I work with most of my clients who come to SSO for counseling. They live with schizophrenia or psychosis. So I often ask this question to family members. How do you know I am real? This purple talking to you, it's a real person. How do you know? How do we stay connected with reality? So usually people would tell me, because I hear you, because when I ask a question, you respond, I touch you, and then I can feel it. So basically we get in touch with reality through our senses. Unfortunately, when people are struggling with psychotic illnesses, oftentimes they have distorted senses. They start to see things that is not there. They actually see it. It's not something they imagine. They hear things that is not there. They feel, they smell things that may not be real. So that cloud their judgment. And the what is real and what is not real, they kind of overlap. It's not completely separate. That is causing a lot of confusion to people who are suffering from it and those who are living around them, just not sure who they are talking to, just not sure why they have certain odd behavior. Psychotic illnesses could be very challenging for a lot of folks, and it could be one of the most difficult ones to diagnose and treat. Eating disorder, we probably know about anorexia and bulimia. What I just want to point out is at the mood level, oftentimes is the person feeling quite sad, unhappy, not satisfied with their body image, low confidence, do not have a healthy self-esteem. At the thought part of it is they are very concerned if they eat more, if they become fat, what could happen? It could be very unhealthy. They could be disgusting. Certain concern in their thought process, and then the behavior would be they are counting their intake calories. They are checking their weight obsessively. It affects a small number of population across the world, but it is the most fatal mental illness. It takes more life than other mental illness just because of when our body is lack of nutrition, it can shut down very quickly and people can die from it very easily. We used to think eating disorder only impact a teenage girl. They are the one obsessed with their image, obsessed with dieting. But we are seeing a trend is actually starting to affect a lot of boys as well. Last but not least is the personality disorder. So this one could be difficult to diagnose, but what we will notice at a daily interaction level is we will see a lot of inconsistent, a lot of drama. This person is pretty difficult to deal with, and one day it could be a nice person, and then the other day it could be a totally different person. We see a lot of tension, and oftentimes this person present themselves as someone who has high need, and there is a lot of crisis around, and they can be best friend with you one day and then they will leave you forever the next day. So some of the psychiatrists that I work with, they will say, oh, people with personality disorder, they fire me every other week and then they come back. So we see a lot of inconsistent in personality disorder. Now I'm going to let Adrienne to talk about suicide.
Okay, so let's shift gears a little bit and talk about suicide for a few minutes. Okay, so let me just begin with the language around suicide. One of the areas that it's probably timely to address is the way we talk about suicide. So, for instance, we have traditionally been saying things like use terms such as successful suicide, attempted suicide, and families who have experienced someone close to them who have died by suicide have raised this issue, and perhaps one of the things we can do is think about how we the terminology that we use around suicide. So the next thing I want to mention is that most mental health problems are associated with some degree of increased risk of suicide. So one must be aware of the possibility that the individual who's experiencing mental health problems may be suicidal, and that might be something that you might want to assess. However, it's also important to know that not everyone who's depressed is suicidal, and not everyone who is suicidal is depressed. So Purple mentioned thought disorders, and sometimes individuals who have a psychotic disorders may be experiencing command hallucinations, voices telling them to engage in something that might result in them harming themselves, or explicitly telling them to kill themselves. Okay. And the other piece is that suicide is the second most the second reason why in young people behind motor vehicle accidents, suicide is one of the leading causes of death. Okay, so just looking at this slide right here, women may attempt suicide or gesture suicide, make suicidal gestures 3 or 4 times more than men, but men die by suicide more often because men tend to use more lethal means when they're feeling suicidal. Okay, I'm just going to skip to the next slide. Okay. Okay, so individuals who are suicidal may believe that they have no other options. They may sense that their family or friends would be better off without them. They may be thinking that they've done something horrible, that suicide is the only option. They may be experiencing unbearable pain and feel that it might go on forever and can't see a way out. And that's often the case with young people who can't imagine that it's going to, that things are going to get better. They may want to escape their suffering. Or they may want to communicate to their loved ones how much they hurt. The other piece to know is that individuals who are suicidal do indicate there are suicide warning signs that we can be aware of. Perhaps there are the individual is expressing negative comments. They might even be expressing an intent to die by suicide, and that they may have a plan to do it. You may see them putting their affairs in order, giving their precious items away, they may be expressing hopelessness or helplessness or desperation. You may know that they've experienced a loss of some kind. They may be manic and engaging in risky behavior, so it may not be a suicidal gesture. They may just be in this euphoric state. Now, some of the things that put individuals at risk, at higher risk of suicide, as I've mentioned, is mental illness. Also, if they've made previous attempts at taking their lives or killing themselves. And again, if they have a plan. So what might one do if you suspect that someone is suicidal? Now, there is a myth that, and this keeps people from talking to individuals who they suspect might be suicidal. They feel that if they bring it up, if they use the word suicide, it might plant the idea in their minds. But this is in fact not true, and we know that for the most part, individuals are actually relieved when someone close to them will ask them about suicide. So what you might want to do is actually ask them if they have thought of ending their lives, if they feel so bad that they've thought about it. And then if they say yes, you might want to then take it a step further and find out if they have a plan. Obviously, what you're doing is you're assessing how serious the situation is. And if someone says that they're going to kill themselves by their next birthday, which is 6 months away, it's there's less of an urgency that gives you more time to work with them, compared to someone, for instance, who says that they're going to go home and overdose. So I would encourage you to have this very honest conversation. Ask them about the plan. Ask them whether they have taken steps. Now, one of the things that you might want to do is, if someone has indicated that they're suicidal, is that you want to stay with the person. You do need to think about your own safety as well. Call for help. Don't deal with the situation on your own. Call 911. And when caring for someone, perhaps in your family or close friend who is suicidal, it is important for you to also do a lot of self-care, because it can be very exhausting, and to not work on your own, to be part of a team. And here on the screen, we have put the distress line. I also want to just mention to you that there are a number of YouTube videos that may be good resources. If you Google for the Jack Project, you will see it on YouTube. And I would encourage you to take a look at those videos. Okay, I'm now going to hand over to Purple to speak about the recovery model.
When we talk about mental illness, in Canada is still we stick with a medical model, which often look at how we can reduce symptoms. But in the last, I would say, decade, we start to see there is a shift in how we look at recovery. So more and more we hear people talk about what is recovery and how can we help people regain the function and be a full citizen in Canada. So the shift is instead of just focusing on how can we reduce these symptoms to how can we actually help the person fully participate in our society. Recovery doesn't mean the person will be symptoms free. Recovery doesn't mean the person is totally cured and now the person no longer have to take medication. In some cases, we do see some people, if they go through a treatment and the treatment is effective, there is a percentage of people they do not have to continue with medication. But for others, they may still need some medication to help them, whether it is going to bed, whether it is to calm certain anxiety, or just to help them get through some challenging time in their life. But recovery focus on how can we help the person regain functions. When I talk to people who have been suffering from mental illness, I ask them, what would you like? What is recovery for you? Oftentimes I hear them say, I want to feel normal. I want to be normal. And normal meaning I just want to be like everybody else. And everybody who is considered normal, quote unquote. They either go to work or they go to school. There is some responsibilities. They have hobbies. They have interests. There is a purpose in life. They have meaningful relationship. They may get married. They have children, just like everybody else. So this is what recovery that we want to promote. People should be able to continue their journey rather than just stay with medication and get stabilized. But once the situation is a bit more stable, we should promote that idea. People can recover, they can be a full citizen in church and in our society. And in the church setting, we can promote that if we focus on the strength of the person and we provide that hope and culture that nurture recovery. So I've seen in some churches or some of my clients, they go to church, and I'll give you a few examples how they can participate in church even despite they are still suffering from some mental health issue. I remember talking to one of the pastor of a client, and this person suffered from OCD. So his obsession is he collects all stationery, and he worry the end of the world is going to come, and he will stay in his own apartment forever. So he stock up on all kinds of supply from stationery because he need to write a SOS note and throw it out the window so someone will save him, and to water, anything that you can think of. And the compulsive part is he will have to accumulate all these things, and he count his inventory on a weekly basis to make sure there is supply. If something is expired, he will donate them and then buy more to replenish the inventory. So one of the things part of his obsession is he really needs to call people. He worry about if he doesn't call people, there may be some accident, something happened to the person. So he has a ritual every day. He has to call at least 3 times the same person, just to make sure that person is okay. So his minister come up with a great idea. Instead of calling me every day 3 times a week, this is the new guests who have been coming to our church. Why don't you call them 3 times a day for the first week to let them know you are praying for them? So this pastor trained this person. You are not harassing them, but there is certain things you can do, and you pray for them in the morning so they have a good day, a blessed day. In the afternoon, you check in how the day are doing. At night, you bless them so they can sleep and they have a family that they are living with. And he loves that. He loves that. Another person who is very depressed, but in his own time, he loves to do Bible study. And the way he contribute and participate in churches, he won't be able to join the worship team, but he loves some one-on-one Bible study with people, especially those who are marginalized, who are ignored, the seniors, and he will do one-on-one Bible study with these seniors at their home. So we need to think of certain ways. How can we promote recovery and use the spiritual gifts of those who are suffering from mental illness and help them journey with us in church? Here is some practical skills and tips how we can help in a church setting. And I'm going to let Adrian talk about it.
Okay, so I'd like to begin with a resource that you might find helpful, and it's a book by Amy Simpson. It's called Troubled Minds. Many people find this very helpful. Amy Simpson writes about her mother who developed schizophrenia when she was young, and her father was a pastor of a church, and how this affected all of their lives. Okay, so how to help? Okay, so one of the things that happens with individuals who have mental illness in the context of a church is that they're suffering in silence, really. So what we want to do is create a safe environment so that they can get treatment, they can be open about their illness, and they can feel supported. And we can all play a part in that. So here are some just some very practical ways in which we can reach out and help people. One of the most important things is not avoiding the issue, but reaching out, engaging, connecting, and being there. One thing that might that might have prevented us from engaging with individuals who have mental illness, maybe some of the myths that we talked about earlier, fear, lack of understanding, um, perhaps not knowing what our contribution can be. And what we want to encourage people to do is to not do it on their own, but to do it as part of a team, and to reach out and to come up with creative ways in which you can involve individuals with mental illness in small groups, in ministry, in church, and be supportive of them, not just individuals who are suffering from mental illness, but also their families who also need help and support, really. So what we want to do next is talk about, make three recommendations, really, about being consistent, being coming up with perhaps a sort of a treatment plan, and sharing it and maintaining it, maintaining love and support, and being being someone that's dependable. And then we do suggest that there be limits to avoid burnout. And for this, it's very important to not be the only person that's ministering to someone who has a mental illness, but to be part of a team, to share it, and to also be very aware of your own level, what you need, basically, and be able to ask for it, to ask for help. And then you want to be collaborative. You want you want to also ask the individual to take responsibility for aspects of their care that they can. You might want to help them to reconnect with their families, and certainly want to support their families as well. Mental illness is, as Popal has mentioned, it's complex, it's multifaceted. There are many reasons, many triggering factors. However, individuals can recover and they can have a good quality of life when they get the appropriate treatment. Again, take suicide seriously, look out for warning signs, and don't be afraid to reach out and engage. Be part of a team and be there for people. And on that note, I'm going to end so that we can leave some time for questions.
Okay, if you have questions, you can either type in, and I guess we are going to unmute people so that you can talk as well.
Over here.
Yeah, don't unmute it. Sweet. You got the sound on.
Okay, probably it is easier for you to be muted and then have your question typed in. Otherwise, it's very hard to hear. Okay, please type in your question. So Irene asked, what's the difference between mental illness and mental breakdown?
Mental illness and what?
And mental breakdown.
Oh. Do you want?
Usually, I would say when we think of mental breakdown, it's probably talking about an acute episode of some form of mental health issue. So let's say if people they have schizophrenia, if they are medicated, maybe they won't be hearing things, they won't be seeing things that is not there. But when we say, oh, the person have a mental breakdown, probably is some of these acute symptoms are coming back, is flaring up. So we can see them interfering with this person's life. But when we talk about mental illness, it could show up in different ways. Some people do not have very obvious symptoms. So if you talk to doctors, they will classify these symptoms, sometimes call them negative symptoms, positive symptoms. Negative meaning those are the things taken away from the person, such as if when I'm well, when I see certain things that is enjoyable, I feel happy, I would participate, but now I miss that. I do not have that ability. My face do not show the emotion. So those are some of the negative symptoms which could be lingering for a very long time. But when we say mental breakdown, probably we are looking at some of these positive symptoms, something added on to the person when the person is not well. We don't see these things in ordinary people, such as most people won't see those things, but the person see it. Most people would say, no, I didn't hear that voice, but that person saw it. Most people would not have those thoughts, even though there is ISIS, but I would not think, oh, because the ISIS are so dangerous, I won't let my kids go to school, I won't let anyone in the family leave my eyesight. Ordinary people don't have the concern to that level. But when we say a mental breakdown, probably is there is some acute symptoms flaring up, interfering the person's function in a significant way.
Janice has a question. Do you have references, books, articles, etc., that could inspire us as to how we can integrate people with different mental illnesses in our faith community?
Amy Simpson's Troubled Minds.
So one of the book that Adrienne just mentioned, it's Amy Simpson's book. We will send this PowerPoint probably to all of you, and some of your questions, if we have further information, we can incorporate those. If there is a PDF file, there are some articles, we can send you the link so you can download those as well. If you go to the working group's website, we do have a list of resources. Some of them are online, you can download it. Some of those are videos that could be inspiring to help you think outside the box. How can I find some creative ways? And some of those are some case studies. How do other churches help people recover? So you can read on those and see if that could be helpful as well.
Is it a good idea to encourage people with mental illness to take up regular exercise?
Yes.
Definitely. There is evidence showing, especially for mood disorder, for depression. Not everybody respond to antidepressant, although a lot of people do. But some people, they just don't like the side effect, or they just don't like the idea of taking medication. And evidence is showing if you can exercise regularly, then that could work as well as medication or psychotherapy. If you are willing to go for therapy, it could work as well as medication. So exercise, definitely. And it goes back to the basic. Like we often, today we talk about mental illness, but if we're talking about mental wellness, how can we stay well? Go back to the basics. It's nutrition, you eat well, sleeping. Sleeping is extremely important for people with mental illness, and I would say if the sleeping you start to see there is a change, the person is not sleeping or sleeping excessively, that is a sign telling you something is not quite right. And then exercise. Those are the three pillars to maintain our wellness. Of course, spirituality as well.
The next question is about suggestion and guidelines for prayer ministry, especially in the context of congregation members sharing very heavy issues or mental illness struggles.
Guidelines around prayer.
For prayer ministry.
I'm not sure if I've got some feedback on this line for some reason, but anyway, I'm not sure whether I'm understanding this question correctly, but prayer can really be can really instill hope in a person. So praying with someone is definitely, it's to be I wouldn't I think it can be very helpful. Is there an addendum on that question, or?
The follow-up hasn't come yet.
Okay. So yeah, I mean, I would encourage to individuals to pray with people with mental health issues. It can instill hope in.
Okay. To clarify, just a lay person dealing with a person with mental illness.
What's that?
A lay person dealing with a person with mental illness.
Okay, so well, actually, perhaps that is a very good question, because there is a difference between prayer and counseling. So you want to, if you're praying with someone, pray with them. Don't try and counsel them through prayer, because you may be getting into areas that are outside of your scope of competency, or stick to prayer, asking God to help, and so on.
If I can add to that, there are two things. One is around confidentiality. So some people, they really don't like to share what they're struggling with. So if it is one-on-one, they trust you. Right? So you are going to keep those information confidential unless you notice there is some suicidal urge, there is a certain level of danger. Then you have to tell the person, I can't keep it confidential because I care about you, I love you, and I need to get you help. The other piece is around just like any form of illness. If someone is just had a stroke, the person has diabetes, when you pray, right, you won't pray for a miracle. You won't pray for, okay, it's just prayer. You don't need to take medication or go to see any medical advice. So when we pray we pray for comfort. We want to make sure it is the companion. It is a way. As a Christian, we ask God to help us. It is a way we talk to God about our need. It is a way to bring comfort, but it is not a treatment.
Okay, it's 2:00. I just want to let people know that we will be sharing the PowerPoint and the audio recording, and that we will be sharing the website of the Mental Health and Faith Organization, and another group called Church Networking Supporting Disability, which is the organizer of this webinar. And there is a Facebook group for you to ask questions. It's a closed group, so it's a safe, secure environment for us to talk about things. But I think the speakers are willing to hang around and answering a couple more questions, but you have to go. I just want you to have that information. Okay, so go for the next question. Is how can we provide support as a team when there may be serious trust issue coming from the person with mental illness?
Trust is always a challenging topic. I would say there are two things. One is you need to understand and listen to the person. So oftentimes you won't be able to offer any help, comfort, unless the person feel you understand me. So listening is way more important than what you can offer. That is probably the best thing you can offer. Even in a clinical setting, when I work with my clients, they have paranoia. They have severe symptoms. They have trusting issue about the medical system. They think the doctors, me, and the police are all working together. So for a long time, and I'm talking about even in clinical setting, I oftentimes have to spend 6 to 12 months just to listen to the person, try to understand where they are coming from, try to understand how they feel. I want to make sure I understand, because it doesn't matter what I can offer if I do not understand the struggle, if I cannot earn the trust. And during that time, when you notice two things, one is the person start to tell you a bit more. That is a sign telling you the person trusts you. And the person start to ask you questions. Then that is another sign of trust. The other, if you see another two things, one is the person shut down, or the person start to attack you verbally. Those are the two signs telling you your communication skill is not there. There is something wrong. And I will start with just listen.
Okay. For those parents whose children are suffering with mental illness, do you think a parent support group will be helpful in terms of their well-being?
Can you repeat that question again? Can you repeat that question again?
Oh, sorry. For those parents whose children are suffering with mental illnesses, do you think a parent support group would be helpful in terms of their well-being?
Definitely. And I would encourage you extend it not just to parents, because there are a lot of siblings who are suffering as well. There are children of someone who have mental illness that is not diagnosed. There are adult children who are well, but their parents are very, very ill. So extend it to friends and families who have someone suffering from mental illness. It offers significant comfort. I run a group in downtown Toronto. It's open to anyone. You don't have to be a Christian. I do not require you have to go to church, but anyone, if you have someone living with schizophrenia or psychosis, you're welcome to come to this group. So in this group, what happens is we offer that mutual support, which you cannot find it anywhere else. Oftentimes families find when I want the help, when I want to talk to people, I have to explain a lot because people don't get it. They don't understand. They question me. But when you go to this group, when you start to share, people get you. They understand. And that brings a lot of comfort and give you the strength to continue this journey. So definitely it's helpful.
I think the next question is important. What should be done when a mentally ill person is regularly causing other people to feel threatened?
So before we continue, I think the person who asked this question, perhaps you can give us some scenarios. What kind of threats? Is it verbal? Is the person stalking people? Is it making any physical threats? Like what is the level of threat? So we can talk about some guidelines about crisis management, but we probably need to know what level of threat that we are talking about. I'm going to share with you like in a clinical setting.
Okay, so the clarification can mean a large man cornering people at church, talking with them loudly.
And what is the content of those conversations? Talking loudly, it could be because the person cannot quite hear themselves. Does it involve any threats that, well, I'm going to hurt you or I won't let you leave?
No.
So based on some of these potential threatening behavior, so usually setting boundary is very important, and you don't want to talk to this person in a closed room where no one else have access to. A practical way probably is have a team that include pastoral staff to sit this person down and tell this person some of the things that bring concerns around safety in the church. And you have to record these incidents so the person doesn't feel you are blaming me, but it has to be factual descriptive. For example, last Sunday at 12:30, you and Mr. So and so were talking at the basement, and we hear very loud noise, and Mr. So and so talked to us later feeling very unsafe. So you describe it, you are not blaming. Oh, you are being challenging, you are being difficult, but you describe what had happened, what was reported to the church, and then ask the person, do you want to give your input? Can you explain to us? And of course, you want to emphasize safety to the whole church is very important. And you do not put up with certain behavior, especially when the person with this size is cornering, like in your terms. So, but you have to describe what cornering, because cornering could be a word that is labeling what the person is doing, and the person may not realize that they are doing that, right? So in a clinical setting, when I work with people who have severe mental illness in a residential setting, some of my clients, they are pretty big. So I have some male clients who are over 200 pounds. So if they corner me, that could be very dangerous. So the first day I start working there, I would tell those clients, when you talk to me, you always have to stay in front of me, and there would be 2 feet away. So it is arm length. You cannot stay closer than that. That would make me uncomfortable. So in the beginning, the person may have a hard time in understanding, right? Because they have a pattern of doing that. My assumption is the person is not doing it intentionally, right? So we want to guide the person to understand what is appropriate. So in the beginning, my clients, they would stand a little too close, and I would just raise my hand and make sure, you know what, this is too close. Remember, I told you it's arm length, but now you are getting more closer than arm length. So step back a bit so we can continue. So you need to do it in a very consistent way so the person understand where you are coming from. But if we are talking about some real threats, the person is making verbal threat, I'm going to kill you, or I'm going to do this and that, right? Or making certain demand that is inappropriate, then I would give the person a verbal warning. We may have to consider calling the police.
Okay, thank you. I think that seems to be all the questions. So, thank you all very much for participating. And